This article, Cutaneous nodule at the site of previous trauma in a 9-year-old male dog, details a case study about a dog that developed a non-cancerous growth called a traumatic neuroma. The article was written by Igor Ribeiro dos Santos, Jacqueline Rader, Guilherme Carvalho Serena, Marcel Bedem Bandinelli, Saulo Pedinati Pavarini, and David Dreamier. It was published in the Journal of the American Veterinary Medical Association. The study was supported by the Conselho Nacional de Pesquisa and Coordenação de Aperfeiçoamento de Pessoal de Nível Superior. Introduction. Traumatic neuromas, also known as amputation neuromas, are the most common reparative lesion of the peripheral nervous system in humans, and have been recognized in veterinary medicine for over 6 decades. They develop due to the unsuccessful regeneration of a damaged or severed nerve. In veterinary medicine, this lesion commonly arises from tail docking, but fractures and post-surgical complications can also result in traumatic neuromas in other anatomical locations. Case presentation: a 9-year-old, male mixed-breed dog presented with a cutaneous tumor on his head that had been growing for approximately 8 months. The owner reported that the dog had experienced trauma to the same site 2 years prior, resulting in a skin laceration. Clinical and gross findings: upon physical examination, the only abnormality found was a 1.5 centimeters diameter, non-ulcerated, poorly demarcated, black cutaneous nodule on the dog's forehead. The nodule was confined to the skin and subcutaneous tissue with no apparent adhesions to deeper structures. The dog did not exhibit any signs of pain or sensitivity associated with the nodule. The nodule was surgically removed and submitted for histopathological examination. Figure 1 shows a photograph of the formalin-fixed cross-section of the excised nodule. The poorly demarcated, white-gray nodule with multifocal round areas can be seen in the skin and underlying subcutaneous tissue. Histopathologic findings: microscopic examination revealed a non-encapsulated proliferation of small nerve bundles, microfascicles expanding the dermis and subcutaneous tissue. Figure 2a provides a photomicrograph of their section, highlighting the unencapsulated proliferation of microfascicles and swollen nerve fascicles in the dermis and subcutaneous tissue. Figure 2b shows the haphazard arrangement of the proliferated microfascicles within a fibrous connective tissue. These microfascicles were arranged haphazardly within a moderate fibrous connective tissue. The proliferating cells exhibited minimal cellular and nuclear pleomorphism, and no mitotic figures were observed. At the periphery of the lesion, swollen nerve fascicles with thickened perineurium were observed. Figure 2c provides a closer look at a swollen nerve fascicle surrounded by thickened perineurium. The thickening was characterized by whorls and layers of hyperplastic perineurial cells and fibroses. Meson trichrome stain and Picrosirius red stain under polarized light confirmed the presence of collagen fibers in the fibrous connective stroma. The proliferative lesion compressed the cutaneous adnexal structures to the periphery. The epidermis overlying the lesion exhibited multifocal, moderate hyperplasia of the stratum spinosum, and mild to moderate keratin retention was observed in the adjacent hair follicles. The excised nodule had microscopic tumor-free margins. Immunohistochemical findings: immunohistochemistry was performed using a polyclonal antiglial fibrillary acidic protein antibody, which revealed intense cytoplasmic immunoreactivity in the proliferated microfascicles. This finding confirmed the presence of Schwann cells. Figure 3a displays a photomicrograph showing the proliferation of microfascicles. Figure 3b depicts the intense cytoplasmic immunoreactivity for glial fibrillary acidic protein in these proliferated microfascicles. Morphologic diagnosis and case summary: the morphologic diagnosis was a traumatic neuroma with swollen nerve fascicles, perineurial hyperplasia, and fibrosis. This diagnosis was consistent with the gross and histopathologic findings. The case summary is a traumatic neuroma in the skin of the forehead of a dog. Discussion: traumatic neuromas typically develop several months to years after the initial nerve trauma, as was observed in this case. While there are no breed, sex, or age predispositions, Cocker Spaniels and young dogs seem to be overrepresented in cases resulting from tail docking. Physical examination often reveals firm, gray-white nodules or swelling at the site of nerve transection. Though pain and sensitivity are common clinical signs, these were not observed in this case. The lack of sensory changes is unusual and may be attributed to the location and size of the neuroma. Surgical removal is a curative treatment option, and in this case, no recurrence or new lesions were observed 2 years post-biopsy. The development of traumatic neuromas is linked to the body's natural nerve regeneration process. Following nerve transection, the distal stump regenerates, stimulated by nerve growth factor released by Schwann cells and trophic factors. This stimulation encourages new axons to grow and reach the distal segment of the nerve, re-establishing connections. However, if the distal stump is too far away or blocked by inflammation or tissue reactions, regeneration fails, leading to the formation of a traumatic neuroma. Histologically, the lesion is characterized by a proliferation of haphazardly arranged nerve fibers containing new axons and Schwann cells embedded within fibrous connective tissue. These nerve fibers often form small bundles, the microfascicles, surrounded by perineurium. While immunohistochemistry can confirm the presence of lesion constituents and rule out differential diagnoses like nerve sheath neoplasms, the histopathologic appearance at the site of previous trauma is often sufficient for diagnosis. From Vet Neuro Jar, keep those minds inspired, hearts light, and tails wagging.